Yeah, just to add some additional thoughts. When you talk about risk adjustment, I feel that it's important to adjust for patient factors that cannot be modified or overcome by putting in more facility resources. And that's the danger that you get into, because there's a high correlation between race and not having access to health care and having poorly funded healthcare systems and poorly funded Medicaid systems. And then just risk adjusting on race, risk adjusts also for an underperformance of the healthcare system. For example, postpartum visits. That's highly dependent upon our healthcare system, but it's also highly correlated with race. Do we want to risk adjust that problem away just on the basis of race and cover up the lack of funding and lack of support to our healthcare system? So I think if you have a population that has immigrated to the United States, that has a high percentage of patients with sickle cell anemia, to me that makes sense. But I think we need to be very careful on risk adjusting poor performance of facilities. And we see this in other areas besides race. And not really looking at patient risk, but we're looking at risks that the facility is giving to patients because of underfunding and not having the proper support in their system. Final comment to reemphasize my concerns about risk adjustment, in that you have facility performance differentials between frontline facilities, facilities that service the poor and service the disadvantaged and even different races and racial communities. One of the ways that you may consider, because I don't think you're going to overcome this or be able to identify facility variables until you have a unified healthcare system, is looking at or maybe working with the Veterans Administration that services all of these entities and has a uniformed healthcare providing system whereby you're going to have more control over a differential quality of medicine being delivered to differential groups. An example of this would be the control of MRSA. I'm constantly hearing risk adjustment for lower income patients and high risk patients with MRSA, yet the VA, who services some of the highest risk population, has by far some of the best control rates for MRSA infections. So this may be a good model. Carol Clancy heads up the quality division of VA. She used to be the director of AHRQ and may be very willing to engage in this, of trying to look at what is their differential in outcomes versus having a population with different races, and then using that as a baseline of what should or should not be risk adjusted for.